So we're going to spend a little bit of time talking about patient satisfaction. And can I tell you, I got interested in this subject for the most personal of reasons. I work a lot of night shifts. I have done that since my children were born. It was a nice compromise to get to be an ER doc and have certain interests, and then still be able to do the other things that I like to do as a mom. And I discovered very early on that by 3 a.m. I am not a very nice person. And so I dove into, a deep dive on the patient satisfaction literature because I wanted to understand what was important and what made a good patient encounter, what the patient experience was, because I thought then even when I'm tired, if I can play it the way they want it, maybe it'll go easier. And again, for very personal reasons, because it is much easier to have satisfied patients than dissatisfied patients. Wouldn't you agree? I mean, the energy that it takes to do service recovery and put out fires when you've got a disgruntled patient or family members, it's huge. And at 3 in the morning, I just didn't have it. So I deep dove on this subject, and before I got my medications straight, it led to reading 84 articles on patient satisfaction. And I've actually put them in a publication that's coming out in the American Journal of Medical Quality in about 2 months, just summarizing all of this. And that's what this talk is a presentation of. So just kind of understanding where we are, there's been an explosion in the research, in particular in the last 20 years, and a lot of it aimed at the ER. It's a cottage industry. Is there anyone who does not have patient satisfaction surveys done at their shop? Anyone? I mean, it's the norm now. Everybody's doing it, and remember, it's going to take on new meaning if these new payment schemes are going to incorporate some element of patient satisfaction. As I say, I'm wondering how it's going to come about, but this is really right around the corner. You kind of have to understand patient satisfaction in the context of quality improvement, and so it begs the question, well, what is quality in the ER, and what is patient satisfaction in the ER, and how can we measure it? We talked about that triad yesterday. Well, we can use a customer service model, which is how well are patients' expectations met. This is what service industries look at. There's a trouble with applying that to our healthcare setting, though. First of all, you have seen this many times where a patient loves their doctor and got really bad care, and you know it, and you know, sophisticated healthcare minds know it. So there's that disconnect. The patient doesn't always perceive that what has been done has really not been the right thing to do from a scientific and healthcare standpoint. Then the other thing that is difficult is patients view their whole care as an episode, don't they? So they can come in with chest pain, and you and your team are all over it. You get them to their angioplasty in 35 minutes. You've done everything right. They like you. They go up to the CCU and somebody's pissy to them. And how will they remember it? So unfortunately, we are often targeted by a different department's brush in that regard because people see it as an episode of care. So that makes it, we have to always keep that in mind. It's a little bit, it's colored, if you will, the patient's experience of care. So a couple of ways that we'll talk about it in getting our arms around is the patient satisfied is to look at overall satisfaction, and surveys will ask this. Would they return for care? A legitimate question. And would they recommend this facility to others? And then the other things, we've been talking about this a lot. Oops, sorry. Door-to-doc times, because we know that correlates with patient satisfaction. Left without being seen, which is a form of complaint. And then just complaints in and of themselves, complaint ratios. You know the range for complaint ratios, typically between 0.6 and about 2.5 per 1,000 visits. That's how we measure it. So there's some very good articles that I'm only putting out there of the 84 that I read, what I consider to be the best and great summaries. This one by Worthington, it was in Emergency Medicine Clinics of North America. It's very good for making the case for why we want them to be satisfied. And one thing, you know, if the patients are happy with their experience of care, they're more likely to be compliant. They're more likely to do what you said if they liked you and had a good experience. We also know in terms of risk management that where there's good patient satisfaction, there are fewer malpractice claims, so that's an interesting correlation. And then also, Press-Ganey has done a number of studies that are showing when the patients are satisfied, then you can retain the nurses, you can retain your staff. So what's good for them is good for us. And I say to you that I believe that when it's good for them, it's kind of a better place to work all around. And then we talked about yesterday, walkaways, you lose money, that's cash going down the street. So there are a lot of compelling reasons to have the patients be satisfied, besides the surveys, besides the C-suites holding your feet to the fire. So a couple of nice reviews. There's one, Benjamin Sun is a name that shows up in the literature over and over. He's been interested in this for a good 15, 20 years. And that was in Annals of Emergency Medicine. And then Edwin Boudreau is another fellow that's been sort of fixated on this patient satisfaction thing. We must have the same therapist and our meds must not be adjusted right, because he's doing what I'm doing as far as focusing on this. And they were nice just reviews of the literature. There are a couple things just before we get into what we do and how that affects patient satisfaction. What about the guy in the bed? Okay, are there any things predictive about the guy in the bed? Like, wouldn't it be nice to know the person that's likely going to not be happy with their care? And actually, there's some data on that. So this guy, who's older, has insurance, by the way, is sicker, and also just your place, non-teaching, this is the prototype of the guy that's going to be satisfied. He's going to be more favorable no matter what you do. I'm not saying we don't pay attention, but sort of nice to know your friends from your enemies in this regard. On the other hand, younger, no insurance, lower acuity. For some reason, we don't make that minority connection very well, and teaching hospitals are going to do lower. I mean, that's just sort of the package of the scenarios when there tends to be lower patient satisfaction. So you can put all of these research into 5 big buckets. I've tried to organize it. What are the big 5 that correlate with patient satisfaction? And this is what we found. Empathy/attitude, a little bit nebulous there, what that's about. Acceptable waiting times always comes up. Technical issues, and I'll show you in the different ways that I mean that. Pain management, which we talked about earlier, very important to patients. And then information, they want to know what's going on, and we probably fall down there the most. So these are your 5 big buckets that you're going to be trying to address in your initiatives. So, I was going to say, empathy, attitude, the interpersonal. Remember I told you, I am not nice at 3 a.m., and I recognized this very early on. So could I cultivate some strategies that would sort of promote that? And for me, I have a few things. I always sit down, right? You sit down because they think you're spending more time with them. Do you need to touch a patient to take good care of them in 2009? I want to suggest to you, probably not. You can work up chest pain without ever touching a patient. So I sit down and I actually do this thing. You probably think it's silly. I pretend I'm taking the pulse. It's a very doctorly thing to do. It sort of meets their expectation. I'm touching them. I'll also often touch their face because, and actually there is something there. If they're diaphoretic, does it change what you're thinking? Oh yeah, all of a sudden I'm on a different note here with this patient if they're diaphoretic. But I have touched them. So there's that contact that they expect, and it somehow connotes to them, you know, that, oh, this is a caring doctor. Do lots of nodding, do no crossing of the arms. And I've just literally just cultivated this. And you know what I've done for a couple of the guys in my group that always get complaints because they're just boorish guys that, you know, there's the huggy teddy bear guy, and then there's the one that just seems to rub everybody the wrong way. And I'll just sit to me like, Kurt, let me tell you 5 things I want you to do now. You got to get a handle on this. And sort of, I believe you can train yourself to do some things that meet your patient's expectations and sort of smooth that encounter a little bit. They might sound silly, they're little things, but I think they can really have an impact. And just because I don't like getting complaints because it's a hassle, I go literally years without complaints. But it's a studied effort. Do you see what I mean? It's not, because I'm truly, my nurses will tell you, you can call them, it's LDS Hospital. She's not nice at 3 a.m., but I cultivate it with the patients and try to with the staff as well. So anyway, Birch wrote a nice review article about the things that matter most, and there was a big focus on that interpersonal experience. Patients love introductions. They just love that. So, and I do forget, sometimes I forget, but I try to do that. And what I find I'm more often doing is after an initial encounter going, oh, I'm Dr. Welch, by the way, if I didn't say so. You know, they really like that. They like knowing who you are and having that little bit of introduction. And especially like, do any of you still have uniforms in your department? We've sort of gotten away. It's sort of unisexual dress. You never know. The guy in the scrubs could be your doctor, your nurse, your tech, your transporter, right? So having an introduction so that they know who you are, I think, is a big deal. The other thing they like in terms of this interpersonal nebulous thing, they like it to seem organized. They don't like it to seem chaotic. It scares them. Pretty hard to do because most of the time it is chaotic. But can you somehow keep the chaos from the patients? Keep that noisy, yelling psych patient in a quieter room? You know, if you've got some people that look like they may be shady characters, can you have security walk by a few times? So can you try to create the sense for the patients that it is organized, it's under control, we know what we're doing here, you're safe with us. Because think about the setup. We know these people, and literally our encounter is about 180 seconds, and now we want them naked, we're sticking stuff in them, on them, through them, you know, and asking them to tell us their most personal stories. So it's really a very unusual human encounter, and anything we can do to make it better for them, I believe in it. How they understand their discharge instructions is important because that's part of almost every patient satisfaction survey. You know it's an open book test, right? You can go back to your shop. Most of them say the same things, but you could go back to your shop and say, can we see our patient satisfaction survey questions? We want to understand, you know, what you're concerned with the patients. And it can be totally an open book test, and you can play to that a little bit. Remember, the patients have a very low, we're appreciating this over time, very low healthcare IQ. And so I think the patient instructions should be 4 lines long and at a 5th grade level and very, very simple. You're going to do this, this, and this, and if this happens, come back, that kind of a thing. Very, very simple. So the other thing is to also get your boost on this particular question, which is pretty universal. You know, did you get discharge instructions? Did you understand them? You go over them, have your nurse go over them as well, so that they're hearing it a couple times. Anybody have a callback system? Oh, that is great. This is such a crowd pleaser, and it's your opportunity for service recovery. I mean, I've used it where I was just like, I don't know why, but I think those people were unhappy. I feel a complaint coming on. Can put them on the callback list for tomorrow, just see how they're doing. Scripting for when it gets gnarly, you know, like, you know that tense feeling when you're running around, you have really, really sick patients, and the lady who was diagnosed by her family doctor with bronchitis yesterday, but comes in for a second opinion, is driving you crazy about, you know, helping her and her needs and so forth. And you just feel yourself getting tense because you think, are you clueless? We have really sick people here. Have a little script, you know, gee, I'm really sorry. Do you know what? I have someone that's quite ill in another room. Let me get back to you as soon as I can. Like, turn on your script. Because if you turn on what you really want to say, you'll probably get yourself into trouble. So these are some of the issues. Of course, your registration people use scripting all the time. Distressed family members have something you're going to say there. Phone call requests. We actually have absolutely required that our staff, you know how you'll get people trying to get medical information over the phone, you know, even from just themselves, they have to turn on a script in the way that they answer it. Drug seekers, do all of you have scripting for that? Like our line, we just went to this pretty hardcore. We do not manage chronic pain at this hospital. We will be happy to give you a referral and get you some help this way. And we turned ourselves from being the candy man for the community where everyone came in thinking they were going to get Percocet or a shot of Dilaudid or whatever they chose, to now they know, wow, they're really stingy there. They won't give you pain medicine. So we turned that around, and we all use the same script. And then when there's long waits, just a little something that you're going to say. And you know what I find? People are very generous. If they know that there are other sick people in the department, and without violating too much privacy information, you just say, gee, I've got a very sick child in the next room, and we're all in there trying to help that child. And what do people say? They're like, oh, doc, go take care of that. I mean, they are very generous. So that much information. My attorneys tell me I shouldn't even be doing that. I don't care. I give them that much information. And also, I don't even care if I give them a little story. I say, well, if you heard the ruckus in the back, somebody came in and was slightly under the influence of drugs and thought that we were all aliens and was trying to get us. You know, just a little story, little colorful story to take home from the ER for having spent a few hours there. And then for sure, angry physicians, that's something we have to tend to. So, you know, have your script out so that you don't go over the top with your own anger. Uh-oh. There we go. And then what you say for complaints. And it's hard sometimes. Do you do it through gritted teeth? I'm really sorry that we didn't meet your expectations. I mean, having a line for that is so well rehearsed that you can get it out through your, you know, clenched teeth is a good idea. So there's some data about what patients like and don't like in their docs. Ladies prefer ladies, and the guys in my group always use this as an excuse to get me to the gynae room. I'm like, wait a minute, guys, let's just share the wealth here, shall we? But as a matter of fact that they do. And there are some subsets of patients, in particular, Muslim, that you really need to set this up for them if you can at all do it. Ooh, wait a minute. They love lab coats. How many here wear a lab coat? Yeah. I mean, would you consider it, would your colleagues consider it, knowing how much patients like it? And like I say, think of the setup. You know them 180 seconds and they got to get naked and you're doing all this stuff to them and they're trusting you. This helps them because this frames it, my doctor, scientist, pillar of the community. Think the things that the white coat connotes. Yeah?
The MRSA.
What about it?
The white coat. It's a collector of bad bugs.
Not if you wash it.
Well, I don't know what to say to that.
In between patients, you're going to wash it? MRSA.
Well, I ain't changing my clothes between patients either, Todd. So I ain't changing my clothes between patients either. We gave each physician in our group 10 monogrammed lab coats, white lab coats, and they're laundered by the hospital.
Right, so just at the end of each shift, culture them. And the difference between a lab coat and scrubs is that scrubs are fitting close to the body and not at risk of brushing up against things. So it's been shown with ties, it's been shown with all kinds of loose. I'm just saying, in this day and age, other considerations.
I'm sticking to this, sorry. Haven't made the case to me. I still think this makes sense. Sandals and jeans, they don't like this. So if you have any California docs that like to down dress, thinking it's hip, patients actually have an opinion about this. They don't like it. They're pretty particular about women, and I admit I couldn't quite nod to this. They prefer a skirt to trousers, and I couldn't quite ever do that. I'm up on a stretcher putting in a dislocated hip. It just wasn't going to work for me, so I don't do that. But in very many other things, I try to accommodate them. Of course, they don't like jewelry, frills, ruffles, long nails, which most female physicians I don't think go for anyway. So anyway, just preference. And then you bring up the tie, MRSA collector that it may be. But as it turns out, this actually does boost the patient's impression of their physician, okay? So they associate a tie with a more favorable view of you. There's only one rub. There's one study that says they don't always remember correctly if you wore the thing. So where do you go with that? We have some docs in our group that just always wear it and like it and feel comfortable with it, and then others that will use that as an excuse not to. So gentlemen, I leave it to you. Your call there. Anybody using business cards? Huge crowd pleaser. And so, and people will always go nuts when I say this. I will actually say, here's my card, and it has the hospital number, not my cell phone, but the hospital number. If you have any trouble, please give me a call. And sometimes I'm worried if the consultant will really see them like they said they would, or is it going to be this thing, you don't have insurance, sorry, I won't see you. But I give them that, and people are like, are you serious? If you have any trouble, give me a call. If there's any other way I can help you. I see the look on people's faces, are you serious? Do you know how many calls I get in a year? And I have been working full time all this time. Maybe 3 times someone will call me back and say, and there'll be a note in my box when I'm coming in next, Mrs. Johnson wondered if you would give her a call. It's surprising to me, and yet what that must do, think of the message that gives your patient, wow, she told me I could call her if I have trouble, and they don't. And I want to say, they honestly don't, and so I just love that strategy. What were you going to say?
I've had 2 in 2 years.
Calling you back after you give them, see, and yet you'd be afraid to do it. You'd be like, oh my gosh, there's going to be 40 calls when I come to work every day. It's not so, not so. And I said this whole compassion thing, and I told you some of my tricks. Anybody else got any other tricks for sort of trying to seem like a nice guy or girl that you're interested in the patient, besides sitting, the touching, any other words of wisdom from the ranks there? All right, then next big correlate. So that's empathy and that whole compassion thing, right? And did they feel like you cared about them and were paying attention to things? So then the next thing is this whole wait time. And we have a couple of issues with it because there are real wait time issues. You know, if somebody's waiting 2 hours to see the physician, that's real issues, and you're going to address that by some of the other things we've talked about, knowing your utilization, having plans for improved door-to-doc time, bedside registration, which I think probably everybody has now, things that will really make it go faster. Also, as I say, matching this, because I still go into ERs as a consultant where there's total demand capacity mismatch. You know, they're staffing for steady state, but this is what's you know, the ER is living and breathing. So, and as we said yesterday, we talked about intake, they will wait 30 minutes, just as long as they'd wait for a table in a restaurant. And it's, there's a great article, I want you to write this note to yourself that you can look at sometime, say you're on a night shift and you just want to look this up. It's by David Maister, M-A-I-S-T-E-R, The Psychology of Waiting. He's not in healthcare, he's in service industries. And he looked at the things that matter to people as far as when they're waiting, when they're in a queue, when they're in a waiting line. And he talks about the pre-process wait. So here's the trouble. When you're in an ER and you're a patient, the pre-process wait is until when? When is it not? Nothing's really happened until what? Till you see the physician. That's the pre-process wait. All this other stuff is fine, but from the patient's point of view, it's the encounter with the physician or the provider that really matters. And so Starbucks got this way before we did. So does anybody remember, you used to go to Starbucks and you'd walk up to be one person and I'll have a double latte with, you know, whipped cream, da-da-da. You do your drink, okay? That person takes your money and then goes and makes your drink as well, because they were all cross-trained to be baristas and register people and so forth. Meanwhile, there's a queue. So if I've ordered 4 drinks to take to the ER on the night shift, and they're making all these little frappuccinos and whatever, the people that are waiting, how long will they wait? Starbucks actually knows this, and they have a better handle of this kind of data than we do. They'll wait 2 minutes. If someone doesn't take their order, then people leave a Starbucks line. They will not wait more than 2 hours. So they got this because they're like, these people are leaving while we're making other drinks. Instead, they put one person on the register. See if you don't remember this now as you go to Starbucks. One person on the register, other people doing the drinks. Because once they've got your money, the pre-process wait's over. Oh, I'm in the system. They're making my drink. Even though the total time to getting the drink in your hand was the same, you perceived, oh, I'm in the game now. I put my order in. So this whole idea of pre-process waits is something that we need to pay attention to in our service. Well, there's that too, but that's because now you're engaged in it. You could, I guess, still walk off, but maybe $5 is a lot to walk away from. So, but anyway, and so you can make these changes, and I'm not going to belabor what we talked about yesterday. Just innovations that actually make the wait better, shorter. But then there's also the perceptions, and one thing you can do is setting expectations. Like you've heard this before, has everyone heard this? So a restaurant, they tell you it'll be 45 minutes to a table, but they call you in 30, you're very happy because you've more than exceeded, you know, you've met their expectations and then some. And so you want to be realistic, although one of our ERs, the Children's Hospital in Intermountain Healthcare, went crazy. They put a big sign in the pediatric waiting room, wait to see a physician 4 hours in the ER. Can you imagine? That did not fly very well. And of course it had the effect of you know, somebody's wrong-mindedness to have people leave instead of waiting. Letting family members be in the room, big on televisions, although anybody had a downside with televisions? They put televisions in the pediatric hospital, and what the attendings will tell me is that they'll be saying to the mother, now let me go over with the medication, and say, Doc, wait, let me finish my show. Right? Is that what you found? Sometimes disengaging the family or the patient from the television set to sort of, you know, finish off their care can be problematic. So we don't universally have them in all the Intermountain Healthcare hospitals. Some places we do. For sure in the places where people are waiting in waiting rooms and, you know, diagnostic waiting rooms and so forth. More and more places are going to, like, let's let them have cell phones, computer access and so forth. How about the idea of giving people a beeper and letting them go away? We'll call you when we're ready to do this. We'll call you when it's time for your x-ray. It kind of dovetails with Jim's idea of a medical mall. I love that, the idea that we, you know, respect their time and that they can be doing something else. So these are all the things that I said, I put television there a lot because I do know that it kind of takes the heat off. And just helping people pass the time. All right, then we talk about the technical issues is our next bucket for patient satisfaction. And I'm talking about a couple different things. This was a study that was in American Journal of Emergency Medicine looking at ultrasound. Are most of you doing bedside ultrasound? Anybody? Maybe have to. So it is a crowd pleaser. They very much like that technology brought to the bedside. I mean, they've shown that that will boost patient satisfaction, even if you don't know what you're doing. If you're still trying to figure out where the heck is that gallbladder, to them, you know, the mystique of the technology. But there's also this thing, and we never really get this, I don't think. How hard it is for you to get their blood or get their IV is huge. Do you know that? I mean, for us, it's nothing. It's like it took 2 tries to get the IV. Big deal. This is huge. That story will be told. Well, I went to the ER and they stuck me and stuck me and stuck me, and that might be a 2-try IV. So you really need to be cognizant of that. And if they tell me, oh, I went to St. Mark's and they couldn't get that IV and they had such a, am I going to send a nursing student in? You're going to send your best person in, your best technical. I mean, sometimes I'll come out and chat with people. I'm like, this lady's really hyper. I guess IVs have been an issue. Can you know, or they tell you, and I got phlebitis the last time they put an IV in me. I mean, you just got to really be, have your antennae up. But there's a total disconnect here between the patient's perception. They stuck me we could stick them 10 times, eh? It doesn't really matter. It hurts, but it's not a health threat. It's on a different level and a different plane for the patient. So best technicians forward, and patients love technology. The other thing is, though, what about medical education? And you know the literature's kind of mixed on this. Some studies have shown that patients are okay. I wouldn't say that there's much in literature that says it's great, it's better to have a medical student on your team. But many, I mean, if scripted and done right, patients will let a medical student do something to them, start a procedure and so forth. There's more data that suggests that they actually don't really like it. So we have to weigh this, because how many of you are at a teaching hospital? So lots of scripting around it, and I still think, remember the old attitude, they came to a teaching hospital, so they're going to get a medical student, or they're going to get an intern. I think in this environment, there has to be a little bit more direct, I have a medical student with me, and I'd like him to be on your case, is that okay with you? And, sort of open information exchange. Anybody disagree with that? I think those days of, you came to a teaching hospital, deal with it, I don't think that's flying anymore. But it does create, and so I'm showing you, this guy was our guy in the ER. Do you have a guy or a lady in your ER that can get an IV on anybody? They can get an IV on anybody. So he's the one we call when this little girl said, they can never get my IV, and she's crying, and we've already got drama, so there he is. Okay, then we talked a little bit about this in a number of arenas, this whole idea of managing patients' pain. Very big to the patients, very big to the families, and for pediatric parents, ginormous. So if you can have advanced triage protocols for giving pain medicine and get your mind around that and get used to it and set it up safely, I think it's a great idea, because having people, I mean, the last thing you want is a complaint to your CEO that someone waited, like what triggered our pain initiative, someone with a kidney stone claimed he waited 2 hours for pain medicine. I thought, well, that can't be right, because we had door-to-doc times of 30 minutes. That can't be right. And sure enough, I looked at the time he got there and the time he actually got something for pain, and he was close to 2 hours. So does anybody have protocols? For instance, I think kidney stones is a great chief complaint to try to write a standing protocol for pain medication. And you would have kickouts, the one that we wrote. You kicked out if you're pregnant, you kicked out if you had a fever, you kicked out if you were above a certain age, and you kicked out if you had hypertension, right? Because that back pain may not be it. But you all know, can you recognize them from across the room? They're pale, they're sweaty, they're holding like this. Sometimes they even tell you they've already had a kidney stone. Couldn't you have a protocol that empowers the nurse, if you're busy, to go and give, say, an antiemetic, pick one, Zofran, and Toradol? So I actually wanted my group to do that. You won't believe this, but anyone here ever had a kidney stone? Personal question. Anyone here have a kidney stone? Okay, so come to Salt Lake with your next one, because my group wrote that you would get fentanyl when you came in presenting like a kidney stone. They didn't want to do the Toradol, they wanted to do fentanyl. I don't care. I'm like, we'll all do it the same, and this will be our protocol, and it'll be safe, and that's what we'll do. And so we have not had a pain-related complaint in a very long time, because we're really into addressing that. We have a protocol, by the way, non-narcotics, For migraines, we have a migraineur protocol that we do, and if they work their way through it, they're still having pain, the doctor has to get involved at that point. We have a number of freestanding protocols that are chief complaint driven to try to get pain addressed. Is anybody still withholding pain medicine for abdominal pain? You know, remember the old days? You have to wait. We don't know the diagnosis yet. Oh, you've got to be kidding me. We have CAT scan. You know, hello, we have CAT scan 3 different ways and with triple contrast if you need to. So I want to encourage you to make sure that pain relief happens in a very timely fashion.
Surgeons don't even touch the patients anymore, they just touch the CAT scan.
Right. Can you call a surgeon without a CAT scan, right? You know? So it's true. Here's just FYI, here's who we tend to undertreat. Kids, probably because we are, you know, a little bit afraid of that. The elderly, of course, because now they're all on so many medications, we're worried about adverse drug events. And then orthopedic fractures like long bone fractures in the elderly we're not quite on top of. Here is probably maybe one of the best tips that you will get. Do you have a scale that you have disabled so it cannot read weights in pounds? Do you know that? So, you know, most of the scales have a flip that you can go weigh it in pounds, weigh it in kilograms. We need kilograms in healthcare, right? Families always want pounds. So this is the most common scenario for pediatric medication errors. I don't know if you know this. So a child has been weighed in kilograms and the parents say, oh, what's that in pounds? How many pounds is that? So the nurse flips the scale. She goes off, the next patient comes in, no one notices that we're weighing pounds. That child gets weighed in pounds and gets exactly 2.2 times the medication that they should get. Does that make sense? And so the ERs that have gotten hip to this just either buy a scale that only weighs in kilograms or disable it. And I think that is a huge, it really is, it's the #1 cause of pediatric medication errors in ERs. You know, even if you have a high volume kid, you probably aren't good enough that your average nurse could say what that child weighs in back and forth pounds and kilograms, eh? So this is just a great tip. So anyway, if you know these people are likely to get under-medicated or medicated too late, maybe you can kind of focus in your department on trying to address that. Most patients prefer PO. Now, of course, if you think they're going to go to the OR, that's a different scenario. But just FYI, most patients actually prefer, this was a study done at the University of Utah, by mouth meds. So I try to have a lot of things stocked that you can be given orally. Let's see. Oh, and then the other area, probably the most common area that we fall down is giving information. How many of you had this where you are making tracks in your ER? You're running around fast and furious seeing patients. And someone will come out and you can tell they're very disgruntled. They'll go, well, no one's checked on us in an hour and a half. And you're thinking, no way. That can't. And then you look at your watch and you realize it has been an hour and a half. Because the time perception for you is very different. Very different if you're anxious and waiting and you don't know what's going on because you're ill or your family member's ill. Different for us where every minute is full and we are multitasking and interrupted 10 times an hour. The time goes by very quickly, doesn't it? So the idea of trying to give information. Now they tried this by doing it by videotape. It wasn't really a success. So, but there's different things afoot. On the other hand, these things have worked. All right, the first one, patient advocate. This is actually someone that works in your ER that their job is to go out and fluff and stuff, I say. Like to go around, give warm blankets, check on people, give information, see if they have any questions. They don't even have to be a healthcare person. You know what I mean? In fact, you could even do it with a volunteer if you want to. It's someone whose job is to just go around and do those little things that seem like, you know, we haven't forgotten you. And can I tell you, as I say, once again, I find patients very generous. If you said, I'm sorry you're still waiting for your CAT scan. We had someone with a bad head injury, but we're getting caught up now. People are good with that. They just want to know. Because they really do think, did they forget me here? Is anybody paying attention? Did my doctor leave and there's no one looking out for me? I mean, these are their worries that they have. The videotape didn't work. Pamphlets sometimes work. Anybody give a pamphlet at the start? Like some places do it. And you can even do particularly long workups like abdominal pain. you can give this is how this is going to go. A pamphlet that explains just the triage process, because you understand this is a huge problem for us. Patients do not understand, hey, I've been waiting here for 20 minutes and they took her back. You know, they just don't get that. They feel that the system is inherently unfair. So giving them a little bit of information that kind of explains the deal helps. And when we're doing abdominal pain, chest pains, we give them a thing that explains that these are very long diagnostic workups, planned for 4 to 6 hours. And then when we outperform the expectation, all the better. But the best one, Studer Group has actually now published this. I used to only get to tell it because I knew it from IHI, but the Staff Service Initiative. So tell me if this would work for you. So you'll usually try to divide it up 3 ways. You, the patient's nurse, and a tech. Every 20 minutes. So at 12:20, I go in. And I say, hey, how you doing? Just want to let you know I'm still waiting for some labs. And does that count as a good encounter from a patient's perspective? Oh yeah, from the doorway, 20 seconds, okay? Then at 12:40, the nurse will go in. Hey, how are you doing? Just wanted to let you know the doctor's still waiting for this information, you know? And then on the hour, the tech. Dr. Welch wanted me to let you know that we're still backed up on the CAT scan, but that's the last thing to come back. Or just give them some sense of progress, telling them that they're not forgotten, and also seeing if there's any little thing that can be done. You know, would you like another warm blanket, that kind of thing. Would that work for you? Could you see your patients on the fly once an hour? Could you like train yourself as you're walking down to poke your head in to the rooms? Okay, there, I got them all here. I mean, some may say, I don't think I could ever do that, but I think it's worth a try. And even if you missed and 2 out of 3 did it every hour, that's going to do wonders from the patient's perspective, because remember what you're doing. They're scared. And they don't understand what's going on at all, and they're worried, they may be in pain, and so those kind of checks. I do think there are many ERs, and I have unwittingly done it, where the patient's been there a couple hours and no one's poked their head in, and think what that would feel like, you know, as a patient. So it's a huge thing you can do. A couple other things that you might or might not know about. The privacy thing, that's pretty important to patients, but not as much as you would think. Like we focus on that. We're talking privacy. They don't want to be denuded in front of the world, okay? But on the other hand, as I told you, surprising studies like that Radit study yesterday, where they'll talk to a roving triage team out in the waiting room and still be happy with it. They'll be discussing their health issues. Cleanliness. I mentioned yesterday taking the walk of shame in your department. This is another thing, because you stop seeing it. I was in the GYN room, and I had been doing this talk for somebody, and I looked, and there was brown body fluid on the wall. And I don't even see it because you know what I mean? Or a patient about 3 weeks ago, a mother said to me, excuse me, there's dried blood on this stretcher. And my son really doesn't like blood. And I was looking like, oh my gosh, you know? So we don't always see it, but the cleanliness thing really matters. And I think painting your ER several times a year, if it's beat hard, is important. Anything we can do to make it look a little bit fresher and cleaner. Then I mentioned the whole ER, it's noisy. There's people in it that your patients would not meet otherwise and would rather not meet otherwise. It feels unsafe, it's chaotic and noisy. So security guards paroling, just like you rotate through, they should have a presence. Just to give the impression, like, we got you covered, no need to worry, you're not in danger. That's the message that you're giving. And then, like I said, that noise pollution. And as I say, most of us don't have enough quiet rooms to accommodate the psych burden of the loud, on drugs, psychotic patients that we get. I am a big fan of vitamin G. Geodon is your best friend. Just put these people out for a bit, especially in the peak times of your department. Little Geodon when they're psychotic. They're going to mellow out, probably go to sleep for a bit. And that's what we routinely do in our department, and we've not had any problems with it. And then let them wake up at 3 in the morning and someone can talk to them then. But when the pedals to the metal in that evening shift and you're over capacity and things are very stressful, the last thing that you, your staff, and the other patients need is somebody that's just out of control. And frankly, you can't spare the 5 staff members to hold the person down and keep them from hurting themselves. I met somebody last week who took off all his clothes, kept throwing himself up against the glass, with for the ones who were in my morning talk, with the patient safety attendant watching, for all that was worth, and then punched the wall until he broke his hand in an open hand fracture. I mean, so I was just like, vitamin G, we'll catch you later, dude. So I think that drug is your friend. Now, here's the thing that I will say that's very controversial, but there are enough mature physicians here that I think some of you might get it. Sometimes patients want things that they don't really need. And you have to find in your, I don't know, conscience, ideology, whatever, how far will you go? So, case number one, lady went to her doctor yesterday coughing, has had pneumonia, is worried about it. Doc said, no, I listed your chest, it's just bronchitis. She's back in the ER, worried, wants another opinion. What does she really want? She wants an x-ray. Can she have it? This is what I say, okay? I'm not going total body MRI, but a chest x-ray, because remember, patients are complex. She is also a person who's worrying, not sleeping, anxious because she thinks she's got pneumonia. I will do that. Same thing, honestly, you can say what you want about audible rules. If people come to the ER, what do they want for their ankle? They want the x-ray. It takes more time to convince them not to have it than to get it. And so I've made my peace with myself, as you will, but I really get, when I'm talking to residents, they get kind of angry about, that's not evidence-based medicine. Maybe not, but these are people. And first and foremost, I would like to do, within my power, give them what they feel they need.
What about antibiotics for viruses?
I try not to go there, as I'm sure you do, but you know what, sometimes when and often this is a scenario, it's the third trip to a healthcare provider, I'll give it to them, I will. You shoot me, but they are happier, and then you know what, placebo effect. Because I've literally had this, in fact it was about 3 weeks ago, someone who I'd seen did the antibiotics kind of half-heartedly, and then she came back in with her daughter and she said, oh doc, I want to tell you I'm feeling so much better. Placebo effect probably, but yeah.
So there's a post-date prescription, and half the time they don't even fill it anyway.
What do you say?
And post-date prescription, if they're complaining of something and they want antibiotics, I mean post-date prescription, and sometimes just have that prescription.
Yeah. And sometimes I'll try to talk to myself, you know what, put this in your wallet, give it a few more days because I really think it's a virus, but if you're not getting better, and you know why they love that? Because you've empowered them. You've empowered them. And I'll do that, like a lot of times anybody had this anxious traveler. Well, I'm getting ready to go traveling and I'm worried because I've got this little cough and so put this in your wallet, and if you start having a fever, feel you're really sick, sure, then you can fill it, and just that somehow empowering them with it. So I'm a big believer in this, and maybe I'm dating myself, and the new scientific docs will criticize me for that. But I think reassurance tests and treatments within reason, and everyone has to find their own sort of conscience in this. But as I say again, they're complex people, and I'm trying to treat the whole person. And if they're so worried about this that they're going to healthcare multiple times to providers, maybe I can meet them halfway with this. So. And don't you, sometimes haven't you been trying to get a handle, somebody keeps coming back and you're trying to get, and sometimes I will just say, frankly, well, what would make this better for you? And sometimes I go, if I could just have some antibiotics, doc, and so if I'm having a hard time, figuring it out, I will simply ask. Now, am I likely to give lots of narcotics? No, I feel pretty strongly about that as well. But everyone has to find their peace, and I don't think it's as black as white as people in academia would often suggest to us, that it has to be evidence-based and there we go. I don't think it's quite as black and white as that. So they're showing you privacy, cleanliness, your safety, that whole noise pollution. This is the very room where the guy throws himself up against the window, breaks his own hand. We have set the floor on fire. This is an infamous room by now. And reassurance tests and treatments. Okay, so your take-home points. Patient satisfaction really does matter, and I want to suggest to you that if you're somebody nobody probably wants to say, anybody in the room get kind of a lot of complaints, and sometimes you feel like you don't know why, I want to suggest to you that you can study this and train yourself to sort of get less by giving the patient the behaviors that they want. And honestly, when they're happy, it's so much easier for you. What's good for them is good for you, and then there's the 5 that we want to remember. Empathy, that little nebulous thing, what can you do to improve that? Technology, bring that. If you're getting complaints, bring your ultrasound machine in the room every time. Ultrasound their finger, for crying out loud. Bring some technology in to help you. That time perception, just making them feel like things are happening, and sometimes the time seems less when they are informed. That David Maister article explains that to you, that informed weights are better tolerated than uninformed weights. Pain control, because waiting in pain is something nobody should have to do, and then giving information. And your scores will go up. Does anybody get what I was doing here with the slide? That's my daughter when she's a little girl and her dog. It was when I was going, we used to talk and I'd be saying, okay, I'm going to show you about a double-blind study. And there's my double-blind study slide. So, all right, thank you. Any questions or comments? Did I say anything particularly controversial? All right, thank you.